Assalamu alaikum. Welcome to all of you today's live webinar program. This is Dr. S.M. Zillur Rahman as the moderator of this webinar. I'd like to express my heartfelt gratitude to all of you on behalf of Physician Tone and Delta Pharma Limited. As you know, today's live webinar topics is very important topics 2020 Global Hypertension Practical Guideline by International Society of Hypertension. And now I'd like to introduce our honorable panel of expert member. At first, I'd like to introduce Professor Dr. Mamunur Sizar, Professor Dr. Mamunur Sizar, Professor of Cardiology, NICVD, and then Professor Dr. Amal Kumar Choudhury, Professor of Cardiology, NICVD, Professor G Azam, Professor of Cardiology, NICVD, and then Dr. Kajol Karmoker, Associate Professor, NICVD. And now I'd like to introduce our very important keynote speaker, Dr. Noor Associate Professor Cardiology in ICVD. Now I'd like to introduce Associate Professor Dr. Zillur Rahman, Associate Professor Cardiology in ICVD. Now I'd like to request to start presentation on behalf of today's live webinar program, Dr. Noor Associate Professor Cardiology, to start the presentation, please.
Thank you, Dr. Imtiaz. Am I audible?
Yes, sir.
Can you see my screen?
Yes, sir.
Okay. Thank you. First of all, I would like to address today's webinar chairperson, Professor Fazlur Rahman sir. He will join soon, and co-chairperson, Professor Dr. Jamal Uddin sir. He will also join soon. We are very much delighted that we have among us Professor Dr. Mamunur Sizar sir as an expert panel, Professor Dr. Amal Kumar Choudhury sir, Professor G Azam, Professor Professor Dr. Kajol Karmoker, and Professor Dr. Zillur Rahman. Me, Dr. Noor, Professor of Cardiology, National Institute of Cardiovascular Disease, is going to present my lecture in this webinar. As you already heard, the title of my lecture is 2020 International Society of Hypertension Global Hypertension Practice Guidelines. First, I would like to show this picture. This is a picture. This picture showing three statesmen in 1945 from left to right. First one is Winston Churchill, then Franklin Roosevelt, and Joseph Stalin. The picture is taken in 1945 February in Yalta Summit during the Second World War. You know, Franklin Delano Roosevelt was found to have hypertension in 1937. At that time, there was no effective hypertensive treatment. And in 1941, his blood pressure was rising and on 88 by 105. During this course, on 1945, Roosevelt's blood pressure was 260 by 150. During that period, Second World War is ongoing. On 12th April 1945, Delano Roosevelt had a massive cerebral hemorrhage that would take his life 2 hours later. At that time, his BP was 300 by 190. So in that period, there was no effective antihypertensive treatment. That's why he has to die. And after his death, of Roosevelt's death, the history taken a new shape. That he died in April. In August, there was 2 bomb induction in Hiroshima and Nagasaki. So In his paper, the personal physician of Roosevelt wrote like this: clinical notes on illness and death of President Roosevelt. Dr. Gruen stated that I have often wondered what a turn the subsequent causes of history may have taken if the modern methods for the control of hypertension had been available then. So this is the Dr. Gruen, the private physician of Roosevelt's, his statement that without effective treatment he died, and after his death there was a tragic history, or there is a tragic history or history in old history. So if we consider the history of development of the hypertensive treatment, we can see that in 1628, the first detection of the circulatory system by William Harvey, and actually in 1913, the essential hypertension was first defined, and the treatment those we are giving, the first actually started in after 1950. The diuretics, beta blocker, calcium channel blocker, alpha blocker, and rash inhibitor, all those thereafter came into the market, and we are prescribing. And there are a lot of guidelines also existing in nowadays. If we can point out some important of them, 2017 guideline for by ACC AHA for the prevention, detection, evaluation, and management of high blood pressure in adults. 2018 ESC published a guidelines for the management of arterial hypertension. 2019 hypertension and in adults, diagnosis and management has been published by NICE guideline. And 2019, the Japanese Society of Hypertension published a guideline for the management of hypertension. So if we look the data of standard hypertension average patient, average peoples in the worldwide, we can see that the deep navy blue color is the 110 average blood pressure, and thereafter red and other colors are raising blood pressure. You see some parts of the world only having these low blood pressure, and many parts like Africa, Asia, these are having raised blood pressure. So among the 1.39 billion estimated hypertensive patient, 1.4 billion are in low and middle income countries, and 349 million from high income countries among the hypertension patients. If we look for some data regarding the hypertensive patient, regarding their poor control of hypertension and less adherence to antihypertensive treatment, this journal has been published in March 2018, Adherence to Antihypertensive Therapy, a missing link between treatment and outcomes. They mentioned that alarmingly, poor adherence to antihypertensive medication is fueling the public health crisis of unsuccessfully treated hypertension, negatively impacting cardiovascular, cerebrovascular, and renal outcomes. Another article published from Africa, the factors associated with defaulting among antihypertensive patients. In conclusion, this article said that increasing awareness of hypertensive complication may reduce defaulting. So there are a lot of defaulters of antihypertensive treatments. This publication has been done by me in 2011 along with Professor M.A. Azhar and Professor Abdul Wadud Choudhury, factors underlying defaulting on antihypertensive treatment. In this research, we saw that the main cause of becoming defaulters were lack of knowledge and misconception, and also the financial constraints that poorer patient could not afford antihypertensive medication. So there are a lot of causes of failure of the antihypertensive treatment, non-adherence of the antihypertensive medication. Despite several initiatives, several guidelines have been produced up to date. But despite several initiatives, the prevalence of raised blood pressure, adverse impact on cardiovascular mortality and morbidity and mortality, and non-adherence to antihypertensive treatment are increasing globally. The large disparities in the regional burden of hypertension are accompanied by low levels of awareness, treatment, and control rates in low and middle income countries when compared to high income countries. There is poor global awareness for hypertension. It is very astonishing that only 67% in high income countries are aware of their blood pressure, and 38% in low and middle income countries population are aware for their hypertension. In both low and high income regions, the ambiguities of latest guidelines are often met with confusion among the healthcare providers, as well as they provoke anxiety among the patients. It resulted in a call for global harmonization. Guidelines from high income regions thus may not fit global purpose. That's why, in this perspective, International Society of Hypertension 2020 has been published to make a guideline for hypertension, global hypertension practice. What are the basic thing of this guideline? International Society of Hypertension extracted evidence-based content from recently published guidelines, and they also tailored the contents and tailored the recommendations. And two important things they introduce, two important concepts the 2020 guideline introduced, that one is essential standard care and another is optimal standard care. Essential standard care means minimum that one can afford, and optimal, that is standard, that is the recommendation that could be done. So what is the basis of these guidelines? The 2020 Global Hypertension Practice Guidelines is to be used globally, to be fit for application in low resources and high resources setting by advising on essential and optimal standards of care, to be concise, simplified, and easy to use by clinicians, nurses, and community health workers as appropriate. So, process of writing, how we can define the goal of this guideline? The goal is not to review the current evidences done by the SCC, AHA, or EST guideline. Rather, they develop a balanced, practical, realistic, feasible, hands-on proposal for global use. They in their guidelines, they put in background ESC, SCC, AHA, and NICE guidelines, but they define it as essential. That means what is required in minimum and what is optimal, the standard care criteria of diagnosis and treatment according to the resource availability in low and medium income versus high income settings. So what is the practical questions to be addressed in this guideline? First, definition of the hypertension, diagnosis of hypertension, investigation, non-pharmacological measures treating hypertension, treatment initiation, stepwise drug choice, combination therapies, goal of the treatment, and when to refer to hypertension specialist, long-term follow-up plan, how to often do we see the doctor or we visit a patient. First, definition of hypertension. These 2020 guidelines make it the hypertension definition very simple. Only two grades of hypertension, grade 1 and grade 2, and on high normal blood pressure. High normal means on 30, the systolic on 30 to on 39, and diastolic 85 to 89. This is high normal. Then from on 40 to on 59, grade 1 systolic, and 90 to 99 diastolic. And grade 2 above equal or above 160 systolic, and above and equal 100 diastolic. So these are they put first definition, they put a very simpler form, grade 1 and grade 2 and on high normal. This is office blood pressure management. That means in hospital, in clinics, or in chamber. And they also recommend the out of office, that means ambulatory blood pressure monitoring or home blood pressure monitoring. So what is the definition in ambulatory blood pressure monitoring? If 24-hour average is more than 130/80, it should be recognized as hypertension. And daytime average 135/85 more than or equal should be considered as a hypertensive. And nighttime average more than 120, equal or more than 120 or equal or more than 70 diastolic should be considered as hypertension. This is for ambulatory 24 hours ambulatory BP. And another out of office BP measurement technique is home blood pressure monitoring. Not 24 hours, but patient can monitor himself or herself. And if the home blood pressure monitoring is over 135 or 85, that is recognized, that is appreciated as hypertension. And office BP, clinic BP, or our chamber blood pressure, if 140 over 90 millimeter mercury, it should be recognized as hypertension. So how to measure a blood pressure? So before measuring blood pressure, patient have to be seated like this, back should be supported, and his arm should be supported on a table, feet flat on the floor, and no talking during and between the measurement, and also 30 minutes before, no coffee, tea, or exercise. Patient should avoid his or her bladder, and patient room environment should be quiet and calm. So in this way, and there both options can be taken for measuring blood pressure, this automatic blood pressure machine or manual blood pressure machine. So 2 to 3 office visit on to 4-week intervals, not single visit. Diagnosis could not be done in a single visit. At least 2 to 3 time patient should come to chamber or our clinic or hospital at on to 4-week interval. Whenever possible, the diagnosis should not be made on a single visit unless BP 180 over 110. If a single visit we can get 180 or 110, then we can diagnose as a hypertension in a single visit. Otherwise, 2 to 3 office visit is needed. So, so there is another home blood pressure monitoring and ambulatory monitoring. Home blood pressure monitoring condition as for office blood pressure monitoring, patient should when patient will take his or her blood pressure in home should sit like office procedure. And ambulatory monitoring routine working day, not in a Friday. Ambulatory routine, not in a holiday. In his daily working day, ambulatory 24 hours should be selected in his or her working day. And device, validated electronic upper arm cuff device should be used in both home and ambulatory blood pressure monitoring. As I mentioned earlier, before when the patient will in home blood pressure monitoring, when the patient will monitor blood pressure, 3 to 7 day monitoring in the morning and in the evening. 2 times patient will monitor his or her blood pressure. 2 measurements on each occasion after 5 minutes sitting rest, 1 minute between measurements. And in 24 hours monitoring, what about the protocol? 15 to 30 minute intervals during daytime and night time, and at least 20 valid daytime and 7 nighttime BP readings should be required. If less, the test should be repeated. This is already tailored programming in the 24 hours blood pressure monitoring. And how about the interpretation? As I just mentioned earlier, average home blood pressure after excluding readings of the first day, 3 to 7 day monitoring needed. So first day more reading should be excluded because their patient may be tensed. So after excluding the first day reading, then 135 by over more than 135 and 85 millimeter indicates the hypertension in case of home monitoring. And in case of 24-hour monitoring, as I mentioned, average 130 over 80 millimeter mercury indicates hypertension, and also daytime average 135 over 85 millimeter indicate hypertension, and nighttime average 120 over 70 millimeter mercury indicates hypertension. There are other 2 terms, white coat hypertension and masked hypertension. White coat hypertension means when patients office blood pressure is increased, but home blood pressure or 24 hours ambulatory blood pressure is normal, then it is called white coat hypertension. And masked hypertension is the reverse. When patients' office blood pressure is normal, but office blood pressure is normal, but home blood pressure or 24 hours ambulatory blood pressure monitoring is raised, that is called masked hypertension. White coat hypertension is less severe than masked hypertension. It has white coat hypertension has intermediate severities. If the patient having white coat hypertension having no other risks, no need to treatment. But masked hypertension patient have similar cardiovascular risks as a hypertensive patient. So this group of patient, masked hypertension patient, needed treatment. What are the diagnostic and clinical tests we do when a diagnosis a patient as a hypertension? So blood pressure, risk factor, comorbidities, signs, symptoms, and secondary hypertension we have to monitor. We have to do all physical examinations, lab investigation like routine lab investigation, as well as the electrolyte, creatinine, EGFR, deep stick test for proteinuria, lipid profile, fasting blood sugar where available, and 12-lead ECG also should be done. This is essential, minimum. We have to do this. And optimal, what is the standard care? Additional tests to consider like all biochemistry test, cardiac test, kidney, brain, vascular imaging, fundoscopy, all tests should be done. So what are the risk factors along with hypertension? More than 50% of hypertension patients have additional cardiovascular risks, most commonly metabolic syndrome, type 2 diabetes, lipid disorder, increased uric acid. Cardiovascular risk assessment is important and should be assessed in all hypertensive patients. Consider increased risks with these are also important along with the conventional risk factor like chronic inflammatory disease, chronic obstructive pulmonary disease, psychiatric disorder, psychosocial stressors. These are also important along with the conventional risk factors. Another important point is hypertension-mediated organ damage, HMOD. Hypertension-mediated organ damage is important for management of hypertensive patient with low or moderate overall risks through a reclassification due to presence of organ damage. So these are important if the patient having class on stage 1 hypertension. So on the presence or absence of hypertension-mediated organ damage, treatment should be started. Preferential selection of drug treatment, and also selection of drug treatment is also important for patient organ damage. Hypertension-mediated organ damage, how we will assess? Essential, it is important. Serum creatinine, EGFR, deep stick urine test for proteinuria, 12-lead ECG, and optimal all other tests to damage of the CT, MRI, eyes for fundoscopy, all other tests for heart and kidneys and arteries, all are optimal. That is a standard care for diagnosis of hypertension-mediated organ damage. This is an important slide. Exacerbators and inducers of hypertension. Often we ignore these. So some drugs or some substance that increase the hypertension. What are those? NSAID, oral pill, antidepressant like tricyclic antidepressant, and some antidepressant like say selective norepinephrine reactive inhibitor, and also acetaminophen, frequently used drug if increased relative risk of hypertension if frequently used, and other medication like steroids, sympathomimetics, anti-migraine drugs, recombinant human erythropoietin. These also increase the blood pressure, and some herbal drugs like ginseng and some substance like licorice. These also increase hypertension. So what are the treatment or management of hypertension? First, non-pharmacological management. Healthy lifestyle choices can prevent or delay the onset of high blood pressure and can reduce cardiovascular risk. Lifestyle modification is often the first line of antihypertensive treatment. Modification in lifestyle can also enhance the effects of antihypertensive treatment. Reducing salt added when preparing foods and at the table. Avoid or limit consumption of high salt foods. Eating a diet rich with whole grains, fruits, vegetables, polyunsaturated fats, and dairy products. Reducing food high in sugar, saturated fat, and trans fat. increasing intake of vegetables and leafy vegetables and beetroot. Other beneficial foods and nutrients include those high in magnesium, calcium, like avocados, nuts, seeds, legumes. So we can order the recommendation for the salt. Salt is recommendation to take salt less than 5 gram per day, and in case of sodium, it is less than 2 gram. But these numericals, we should be cautious that if a single piece of chicken fry, it contains 1100 milligram sodium, or limit is 2 gram sodium only. And simple this fried contain 190 milligram salt, this French fry, and noodles this on 1284 milligram sodium, and salted fish 433 milligram sodium. So sodium requirements is the daily is less than 2 gram, and total salt is less than 5 gram. So we should consider this type of food. This sauce containing 160 milligram on teaspoonful. So we should be alert to restrict our salt. Moderate consumption of healthy drinks, coffee, green and black tea, it is good. And no safety limit of alcohol, but there some literature mention a small amount of alcohol may be good. Reduce weight and avoid obesity. Be careful with complementary, alternative and traditional medication. Smoking cessation, sorry. Smoking cessation should be encouraged. Engage in regular moderate intensity aerobic and resistant exercise, 30 minutes on 5 to 7 days per week. Reduce stress and introduce mindfulness. This is also important. Reduce exposure to air pollution and cold temperature. This is introduced in this guideline for that air pollution and temperature variation of blood pressure. Drug treatment for hypertension management. These 2020 guidelines make a very simpler form of that drug treatment. They in grade 1 and grade 2. If the blood pressure is in grade 2, that is more than 160 and 100 millimeter mercury, start treatment. Both essential and optimal. Start treatment. If the blood pressure is grade 1, that is on 140 by 159 systolic and diastolic 90 by 99, 90 to 99, then first assess the patient. If the patient has any risk factor or organ damage, like risk factor like cardiovascular disease, chronic kidney disease or diabetes, or any evidence of hypertension-mediated organ damage. If any evidence with grade 1 hypertension, should start treatment. If there is no evidence of this risk factor and no evidence of target organ damage, then put the patient for lifestyle modification for 3 months. If blood pressure within come to normal, then no need of medication. If after 3 to 6 months, with lifestyle modification of grade 1 hypertension without risk factor and without target organ damage, blood pressure do not come to normal level, then start treatment. And what is the treatment goal? Target BP reduction. This is important. This is an important addition in this guideline. First of all, they optimally targeted that blood pressure should be reduced below 140 and 90 millimeter mercury. But they pointed out that in spite of this, if blood pressure is reduced systolic 20 millimeter and diastolic 10 millimeter mercury, that will be essential, or that will be the primary goal of this 2020 guideline. And standard care, of course, blood pressure less than 65 years, less than 130 80 millimeter mercury, and more than 65 years, less than 140 90 millimeter mercury. But try to keep it less than 130 by 80 millimeter mercury if patient tolerate. And BP control should be within 3 months. What are the medication should be used? This is also very simpler form. Step one is dual low dose combination, ACE inhibitor ORB plus calcium channel blocker. Then step 2, dual full dose combination, increase the dose of ACE inhibitor and ARB. These are all single combination pill. And step 3, triple combination. Third one should be thiazide-like diuretics. And step 4, if are not controlled with these 3 drugs, then add 4th drug. That means resistant hypertension. 4th drug should be spironolactone or other drugs. And this is the optimal care, standard care. consider monotherapy and the first step on is the dual combination pill, but they also recommended for considering, they also recommend to consider single therapy or on tablet in low risk grade hypertension and very older patients. Consider a ACE inhibitor ARB plus diuretics in post-stroke, very elderly and incipient heart failure patient or calcium channel blocker intolerance. Though those patients not tolerate calcium channel blocker or very elderly patients sometimes do not tolerate the calcium channel blockers, they should be advocated ACE inhibitor ARB plus diuretics. In black patients, this ethnic variation, this 2020 guideline also emphasizes put some emphasis on ethnic variation of treatment of hypertension. As we know, black patients having a tendency to develop angioedema in ACE inhibitor ARB, so they recommend for black patient calcium channel blocker or plus diuretics. And also caution with spironolactone or other potassium sparing diuretics when estimated GFR less than 45 and potassium level more than 4.5. So these all are the optimal care. But these guidelines also recommend the essential care. What is the essential or minimal care? Use whatever drugs are available with as many as the ideal characteristics. So use whatever drugs is available in hand or in a low resource, in a poor patient. Use free combination if single pill combination are not available. If a single pill combination are costly, then we can add two drugs. Use thiazide diuretics, then thiazide diuretics. As we know, thiazide diuretics are cheaper than thiazide-like diuretics. Optimal care includes thiazide-like diuretics, but essential care includes thiazide diuretics. Use alternative to dihydropyridine calcium channel blockers. If these are not available or not tolerated, they recommend as essential. They recommend as essential care non-dihydropyridine calcium channel blocker like diltiazem or verapamil. And last of all, they recommend consider beta blocker at any treatment step when there is a specific indication for beta blocker like heart failure, angina, post-MI, atrial fibrillation, younger women, or planning for pregnancy, etc. So ideal drug, I will skip this slide. So what is the summary of the drug treatment? Drug treatment threshold on for more than 140 over 90 millimeter mercury, and optimal care less than 65. We should try to less than 130 80 millimeter mercury and more than 65 on 40 less than 140 90 millimeter mercury. And that I mentioned earlier. In essential care, they recommend that no specific level, just first lower down the BP, systolic BP 20 millimeter mercury and diastolic BP 10 millimeter mercury. And also the up titration of the target of the following dose. First low dose ACE inhibitor ARB plus calcium channel blocker in step 1, then second step full dose of ACE inhibitor ARB plus calcium channel blocker in second step, then third step ACE inhibitor or ARB plus calcium channel blocker plus thiazide-like diuretics. In fourth stage or in resistant hypertension cases, including these ACE inhibitor plus ACE inhibitor or ARB plus calcium channel blocker plus thiazide-like diuretics, spironolactone could be added. Consider other initial combinations for a specific patient subgroup. Use single pill combinations where possible. Use thiazide-like diuretics preferentially. This is optimal. And but essentially they recommend that we can use thiazide diuretics also instead of thiazide diuretics, considering the cost effectiveness. And essential care where less ideal agents are available, as I mentioned earlier, first point, no specific target, first reduced 20 millimeter systolic and 10 millimeter diastolic pressure. A specific circumstances, resistant hypertension, as I mentioned earlier, resistant hypertension is defined as the office blood pressure more than 140 90 millimeter mercury with at least 3 antihypertensive drugs, including a diuretics in maximal dose and maximum duration. So before diagnosing a resistant hypertension, first consider or first exclude pseudo-resistant hypertension. What are the causes of pseudo-resistant hypertension? White coat effect, non-adherence to the treatment, incorrect BP measurements, errors in hypertension therapy, these should be excluded before confirming a diagnosis of resistant hypertension. And also exclude the substance-induced hypertension as a contributor. As I mentioned, the substance that can induce hypertension. And optimize health behaviors and lifestyle. Consider changes in the diuretic-based treatment prior to the adding fourth antihypertensive medication. How will treat resistant hypertension? Before prescribing spironolactone, we should know the renal function. And what are the other drugs, fifth or sixth drugs we can consider? Amyloride, a diuretics, doxazosine, eplerenone, a mineralocorticoid antagonist, clonidine, a central-acting sympathomimetic, beta blockers. We can also add to the spironolactone. And also we have alphazocine, alpha blocker we can add. The specific circumstances of secondary hypertension, we should be concerned about the secondary hypertension. So when we gauge the secondary hypertension, we have to do some investigation, like before investigation we have taken history and examination, then basic blood biochemistry including serums, electrolytes, EGFR, thyroid function test, and also look for proteinuria. This is the essential. And optimal care means we have to look for all biochemistry regarding the diagnosis of target organ damage also. Specific circumstances, hypertension in pregnancy. This is very important. There are 4 aspects of hypertension in pregnancy. The pregnant patient might have pre-existing hypertension, that is, if hypertension persists before pregnancy or less than 20 weeks of pregnancy, this is pre-existing hypertension. Gestational hypertension is defined as if pregnant lady having hypertension after 20 weeks of gestation, and preeclampsia and HELLP syndrome. These are the pregnancy-related complication that is associated with hypertension. So hypertension in pregnancy affects 5 to 10% of the pregnancies, although maternal risks include placenta abruption, stroke, and long-term risks of cardiovascular disease. Fetal and newborn risks include fetal growth restriction, preterm delivery. These all complications could happen in case of pregnancy, hypertension with pregnancy. Sort of the essential care, office manual auscultation or an office automated upper arm BP device validated in pregnancy. This should be a minimum, or optimal standard if a patient can avail 24 hours ambulatory BP or home BP monitoring could be also be done. And what is the prevention of preeclampsia? Aspirin we can add, oral calcium we can add. What are the increased risks for hypereclampsia, preeclampsia? First pregnancy over 40 years of age, pregnancy interval more than 10 years, BMI more than 35 kg per meter square, multiple pregnancy, chronic hypertension, diabetes, CKD, autoimmune disease, hypertension in previous pregnancy, and family history of preeclampsia. So management will hypertension in pregnancy more than 150 over 90 millimeter mercury in all women. We should treat hypertension, and if more than 140 and 190 along with the hypertension mediated target organ damage, then we have to treat. What are the drugs we used in pregnancy patient? Methyl dopa, beta blockers, and dihydropyridine calcium channel blockers. And we also, what are the in emergency cases in hypertension in pregnancy, if blood pressure more than 170 millimeter mercury or 110 millimeter mercury, the emergency cases, we have to immediately hospitalize the patient and initiate IV labetalol. Should be the drug of choice in emergency cases of pregnancy-induced hypertensive patient, and alternatively nicardipine or hydralazine we can use, or if the patient is settled, then we can reuse the oral methyl dopa or dihydropyridine calcium channel blockers. We also have to give magnesium, and if pulmonary edema, we can use IV nitroglycerin. Delivery in gestational hypertension at 37 weeks if asymptomatic, but delivery could be faster if there is a complication like hemostatic disorder or HELLP syndrome. HELLP syndrome means hemolysis, elevated liver enzyme, and low platelet count. So what are the other conditions? Hypertensive emergency. Emergency means immediate care. Blood pressure should be low down immediately with IV drugs, and urgency means without target organ damage, but elevated blood pressure, need not to IV, but only oral drugs. So I will show some emergency cases. Malignant hypertension, when the blood pressure is over 200 and 120 with retinopathy, then we have to consider the malignant hypertension, and blood pressure should be reduced 20 to 25% within hours, and labetalol and nicardipine should be the drug of first choice. Nitroprusside also could be used. Hypertensive encephalopathy immediately should be blood pressure should be reduced 20 to 25%. Drug of choice labetalol, nicardipine. Second choice nitroprusside. Ischemic stroke. In case of ischemic stroke, we should not start antihypertensive therapy unless the blood pressure is more than 220 or 120. If the ischemic stroke patient having blood pressure 220 and more than 220 and 120, then we can lower the blood pressure by labetalol or nicardipine. But if the patient, if the ischemic, if the acute ischemic stroke patient having indication for thrombolysis, then treating blood pressure level is a bit lower than more than 185 or more than 110 millimeter mercury. If blood pressure more than 185 over 110 millimeter mercury, patient having indication of thrombolysis, then we can lower the blood pressure. Otherwise, ischemic stroke patient to start the antihypertensive therapy threshold is higher, more than 220 or 120 millimeter mercury. But hemorrhagic stroke, if systolic pressure more than 180, we have to reduce the blood pressure by using IV labetalol or nicardipine. In acute coronary syndrome, we have to keep the blood pressure less than 140. The drug of choice is nitroglycerin first and labetalol. In acute pulmonary edema, drug of choice is nitroglycerin, and blood pressure should be reduced less than 140 millimeter mercury. And aortic dissection or in aorta emergency in aorta diseases, blood pressure threshold is lower. We have to start blood antihypertensive medication less than 120 if blood pressure more than 120. So we have to keep blood pressure less than 120 to 60. Again, the drug of choice is nitroglycerin. And in eclampsia and preeclampsia, drug of choice is labetalol or nicardipine, and also you have to give magnesium sulfate. My last few slides, I will just show some comparison between different guidelines, 2020 ISS guidelines and European guidelines. You see, this lower panel is ESC guideline 2018, and this is the 2020 International Society of Hypertension guideline. This guideline is most similar to this ESC guideline, but these are more simpler form, as that these three high normal hypertension stage 1, hypertension stage 2 is similar with this International Society of Hypertension. But there are some differences, but some upgradation or some addition with the ESC guideline 2018 with the 2020 guideline. As I mentioned earlier, they introduce optimal care and essential care. Essential care means minimum, and optimal care means standard care. And they also recommend that 2020 guideline recommend that confirm ambulatory blood pressure monitoring or home BP if possible. They recommend this out of office BP measurement, and they do not have a CV risk assessment tool as ESC guideline. And regarding the treatment aspects, they mainly focused on grade 2 and high risk grade 1 treatment for the hypertensive patients. And other points, difference between ESC guideline and 2020 guidelines are they introduce new points in lifestyle intervention like stress relief, stress reduction, and avoid air pollution. Also, the emphasis on temperature variation. At cold temperature increases blood pressure, and hot temperature reduces blood pressure. So initial drug treatment, they, as I mentioned earlier, they recommended the optimal care as ESC and other guidelines, but they also put some note that as an essential care, one can add any drug that reduce blood pressure effectively. And also in further treatment, again, any drug could be added to reduce blood pressure effectively. And I also mentioned that treatment goal should be less than 140/90, but essential is needed. First, have to reduce the blood pressure, systolic 20 millimeter and diastolic 10 millimeter mercury. What is the comparison between SCCR guideline 2017 and 2020 guideline of International Society of Hypertension? The main difference is the threshold for treating hypertension. As we see that the upper high normal BP on 39 by on 39 is considered as a stage on hypertension SCC guideline. So in this American guideline, SCC and AHA guidelines recommends treatment in low blood pressure patients according to their guideline, but they are on 30 high normal. They do not require treatment in this 2020 guideline unless there is a very high risk, associated high risk or organ evidence of organ damage. There are some differences in the Japanese Society of Hypertension guideline. Japanese guidelines normal BP less than on 2080 in contrast to 2020 guideline on 3085. There is some difference. And Japanese guidelines, Japanese Hypertension Guide Society of Hypertension guidelines has a elevated BP. That means elevated BP is on 30 by on 39. That is considered in 2020 guideline as high normal BP. And 2020 guideline diagnosis of hypertension is made by repeated office BP, but sometimes they advocated home BP. But in Japanese Society of Guideline, diagnosis of hypertension is made by both office BP and home BP. When an office BP is based diagnosis differs from a home BP based diagnosis, the latter is prioritized. So home BP is more important. So there is others in some other aspects there is some difference, or 2020 guideline puts some emphasis on several issues in lifestyle modification. As I just mentioned earlier, they they mentioned that to reduce stress or to keep mindfulness and complementary alternative of traditional medicine. They 2020 guideline does not or did not discourage this alternative guideline or alternative medication or traditional medicine, and they also recommend exposure to air, indoor cold and air pollution. They also emphasis on this type of lifestyle modification. And Mr. Chairperson, in conclusion, I would like to say it has been observed that a recent flurry of updated evidence-based guidelines arising mainly from high-income regions and countries, including USA, Europe, UK and Canada and Japan. However, the adoption of guidelines from high-income regions are sometimes impractical as low resource setting. Treatment of hypertension is individualized and is based on stages, risk factors, and state of target organ damage. Availability of resources should be considered in treating hypertension. What are the new developments? New developments include introduction of the optimal and essential care concept, redefining hypertension as hypertension is defined very simple way in the 2020 guideline, initiating a treatment with a single pill combination therapy, and advising order out of the BP measurement. So this was my slides. Thank you for your patience hearing.
Thank you so much. It's a brilliant presentation. I'd like to thank heartfelt thanks to Dr. Noor sir, Associate Professor Cardiology Department and SCVD. It's a brilliant presentation. Now I'd like to introduce our Co-Chairperson, Professor Dr. Fazlur Rahman, Professor of Cardiology, University Cardiac Center, Mamunur Sheikh Mujib Medical University, and President Bangladesh Cardiovascular Interventional Society. And then Co-Chairperson, Professor Dr. Jamal Uddin, Professor of Cardiology in SCVD, and Director in SCVD, and General Secretary, Bangladesh Society of Cardiovascular Intervention. Now, I'd like to request your comments, please. At first, I'd like to request our Honorable Chairperson, Professor Dr. Fazlur Rahman, sir.
Thank you very much, Dr. Noor. You gave a elaborate outline of diagnosis, treatment, and latest update, different guidelines, and combination of guidelines and comparison of the guidelines to treat the patient of hypertension. As you know, hypertension is one of the important cause of cardiovascular mortality, as it may be symptomatic or asymptomatic. A group of patients remain asymptomatic, but the effect of hypertension is going on and increase the mortality. That is why hypertension is called a silent killer. it is very common, and we have to practice day to day. We get the patient regarding hypertension. But what I want to know our speaker, there is so many guidelines. American Heart Association, European guidelines, International Society guidelines, Japanese guidelines. But which one is applicable for the people of hypertensive people of our country? This is one of the question to our speaker. And another one, what about beta blocker in the first line of treatment of hypertension till date?
Thank you, sir. Thank you, sir. Am I audible? Imtiaz?
Yes, yes.
Sir, thank you, sir. Actually, it is a very important question that you raised, sir. Important question as well as issue. First of all, there are a lot of guidelines, but as I mentioned that the guidelines are coming since the day-to-day guidelines are coming and updated. But still, there are many hypertensive patients still persisting. And as I show that there is a 67% of patients in a high-income country not have their hypertension. So, now the question is, or the consensus is those guidelines are all fit or all competent to control the hypertension in hypertensive patients? I think this all guidelines are some have pros and cons, some and good and bad side. But these 2020 guidelines, they try to balance the state, and they try to simplify. They try to minimize. They try to make a acceptable on of the guideline for both high income and low income countries. But I think still, last of all, I would like to say that hypertension treatment should be individualized. And patient should be treated individualized with his own merits. And the physician is the best judge to take decision which treatment or how we will treat the patient according to the various guidelines. And last, in your second question, sir, the beta blocker didn't have any role in these guidelines. But if they recommend that they do not discourage using beta blocker if there is a other indication like ischemia, heart failure, or oversympathetic drive. They didn't discourage. They can use beta blocker. And last of all, in this 2020 guideline, they put a addition that in essential care of treatment, beta blocker can be added if it reduce blood pressure. So it does not discourage. So thank you, sir, for your important question.
Sir, Dr. Mir Jamal Uddin, sir, today's co-chairperson of this webinar. Please say, sir, some comments about this presentation. Mir Jamal Uddin, sir.
Are you hearing
Yes,
me?
sir.
Okay.
Yes, sir.
Thank you. Today, this is my 5th webinar. From 10 to 11, 11 to 12, then from 5 to 7, 7 to 8, and this one, 8 to 8 to 9. Every webinars I have attended today. Only one at noon heart failure that I missed due to technical errors. Anyway, whatever the number of webinars, that is not the important. Important thing is the topics as well as discussion on it. So far I have heard the speech of Noor. She has covered all the aspects regarding the management of hypertension, its etiology, its diagnosis, and overall risk factors. Everything he has mentioned. There is nothing to tell more over his speech. Even then, as because chairperson we have seated here, so there is some value of chair, and that is why we shall have to tell something addition. The management of hypertension, it's important, very important, as because you have shown the data how many percentage of people are unaware of hypertension. This is the disease where there is, we see the iceberg, like iceberg, that is 9% is under the water and 1% is above the water, meaning that the people who are hypertensive, they do not know, number one. Number two, they are not aware of managing the hypertension. And this is the problem, and that is why the complication of hypertension occurs. We get the patient has come with severe hypertension and with CVD and patient death. This also happen without knowing the patient, without knowing the party that that is he or she is suffering from hypertension. And very miraculously, you can tell that even in the standard standard countries like Europe, there is also unawareness of hypertension and management. There, one is our unawareness, and another is uncontrolled. Then a large number of patients are uncontrolled hypertension, and so our duty now, this speech is for mostly for doctors and patients. We shall have to deliver. We shall have to deliver the things, as because Noor Alam has told everything, scientific everything, and we shall have to tell, to introduce into the patient's mind, or in the general population. We shall have to reach the message that uh, diagnose the hypertension and treat the hypertension adequately, then your complication will be less. And hypertension, if while hypertension is well treated, then the patient's complication will also be less, like diabetes mellitus. And hypertension is also like that. So we shall have to uh, uh, produce the awareness to the people, and then it will be helpful. And it is the duty of doctors as well as the pharma that to make some programs, and that this program will be in different settings, not in National Institute of Cardiovascular Diseases, not in Hotel Sheraton. It should be spread to all over the country, to all the people who are suffering from the hypertension, all the people who are unawareness of the hypertension, and only then we shall be success, and our patient will get benefit. Today with us, Professor Amal Choudhury, and one cath lab performer, Professor Professor Ghulam Azam. He is putting on mask, I have seen. Probably he was in cath lab. Professor Mamunur, Rashid, Sizar, and Dr. Zillur Rahman, Dr. Kajol Karmoker. Everyone should participate in the discussion. So I have concluded with these few
Thank you
words.
so much, sir,
Thank
for
you.
your
Thank you.
excellent view, observation, and suggestion. Thank you so much. Now, I'd like to request to Professor Dr. Mamunur, sir, for giving some comments about this presentation.
Thank you, Dr. Ramtiaz. Actually, I missed the lecture due to power failure in my house. And what I heard from the lecture of the Dr. Noor Alam, he covered all the things. I think so. What I received, that is he said the complication of the hypertension and management, and that is what should be the most giving importance regarding the treatment of the hypertension. Uh, I want to say that hypertension actually is called, that is the silent killer. It is absolutely true, because the most of the patients initially are asymptomatic, and when he develops symptoms, sometimes it is a little bit late period. That is, sometimes he develops with the renal complication or cardiac complication or others. So the with the comments of our director sir, Professor Jamal Uddin sir, I also want to add that the early diagnosis is important, and early statement of start of the treatment is important. So by this initiating the treatment, we can avoid the complication of the hypertension, because hypertension has a lot of complication in the eye, in the brain, in the heart, in the kidney. So thank you for giving the fascinating lecture by the Noor and our chairperson, Professor Mijawan sir, for his comment. Thank you.
Thank you so much, sir, for your views. Dear viewers and audience, our co-chairperson, chairperson, and panel of experts. Today's topic was Global Hypertension Guideline 2020 by International Society of Hypertension, and this webinar is powered by Anine Losartan Potassium and Silocalcilidipine, and scientific partner is Delta Pharma Limited. Now, I'd like to request to comments on this presentation, Professor Dr. Amal Kumar Choudhury, Professor of Cardiology, NICBD. Please, sir.
Thank you, Dr. Imtiaz, for inviting me as a panelist. Thank you. First, I like to thank you and your organization, then chairperson and co-chairperson, my respected Professor A.K.M. Fazlur Rahman, also president of BHI, and also Professor Jamal Uddin, also my director and also Secretary General of BHI, and my friend Mamunur, Rashid, Sizar, and Professor Kajol Karmoker and G Azam. First, after this, I like to congratulate the Noor giving a very, very elaborate and extensive lecture, compiling all the guidelines, authorities guideline, including for Africa to Asia, Asia to Europe and America. It's a very leveraged job. I think he did very leveraged job. But in one lecture, we cannot guess. Really, to me, I don't know about others. It is a guess to grip in brain. It is very difficult. All of you know that why hypertension is very essential to know every physician, not cardiologist, every physician, because it is a very silent killer disease. It is the major risk factor of ischemic heart disease, major risk factor for CVD, major risk factor for CKD, for all the non-communicable killer disease. The hypertension is the key maker. I like to start my comment in a very short statistics of USA in regarding the Professor Mirza Ansar's comment that everybody of America's hypertensive patient, 90% people suffering from hypertension knows they have hypertension. 90%, 90 to 95% is very good. But 75% will take treatment, regular treatment. It is also good. 75% is not a small number. But the sad story is that the oil control, in which level all that hypertension-mediated target organ damage, recently said, before we told that TOD, target organ damage, is only 29%. Only 29% is oil control. In which level they got the benefit of controlling hypertension. So this is a very bad story, even in USA. 90% awareness, 70% treatment level, and good control is 29%. In which level we got the result. So we should address the hypertension in different level. We did not understand pros and cons to treat the hypertension in any guideline. It shows us the hope or better management in this subcontinent. In our country, we must take the guideline, take the treats and bits from that guideline, whether it may be from Russia, from Africa, from subcontinent, or even then America and USA. We must take it. Noor said some new things, optimal care and essential care. It is very important. And mass hypertension, I think it is also very addressing things in our country, in our population. We deal daily practice. I think we think there is a lot of mass hypertension patient. White coat hypertension we know very from our starting of medical life. We know the white coat hypertension it is not so uncommon, but mass hypertension we must address it with adequate treatment and explore how to explore this mass hypertension. I like to say and emphasize this point. And also very good learning from 22 guideline that ARB SC inhibitor should be started individually, but low dose, then high dose, then diuretics. And one thing again come when beta blocker is sought out or it displays from the first line, second line, even then third line, then like me, all the people think that the very good drug, why it does not retain in first line or second line, even then in third line. But in 2020 guidelines include that who have angina, who have hypersympathetic activity, and other neural shows it their slide, his slide very nicely. I think lot of situation, and we can individualize to add the beta blocker. I think this is my comment in today's Noor presentation. Thank you, Noor. Thank you, Dr. Imtiaz. Thank you.
Thank you so much, sir, for your elaborating observation. Thank you so much. Now, I'd like to request Professor Dr. G Azam, sir, Honorable Professor, Cardiology Department in SCBD, for giving these views on this presentation. Professor Dr. G Azam, sir.
Hello, am I audible? Am I audible?
Yes, sir. Yes, sir. Yes, sir.
Thank you very much, organizer and respected chairpersons and co-chairpersons and distinguished panelists. Really, it's an honor and privilege to be with you in this wonderful webinar. This is my 6th webinar. Now I'm on dinner table, but really I enjoy a lot and I learn a lot. But one observation, what I have, beta blocker is no more class 1 drug indication. It's based on trials which cannot reduce central out. Hello? Hello? Audible now? স্যার এখন তো জোরে বলি না, আস্তে আস্তে বলি ডিনার টেবিলে তো স্যার।
আপনি কোথায় খাইতেছেন? খাইতে গেছেন কোথায়? কোথায় খাওয়া দাওয়া করতে গেছেন?
যেহেতু সেন্ট্রাল ব্লাড প্রেশার কমায় না, সেই জন্য বিটা ব্লকার স্যার একটা বিটা ব্লকার ব্লাড প্রেশার যেহেতু কমায় না স্যার, সেই জন্য এখানে এটাকে কোনো গাইডলাইনই রিকমেন্ড করা হয়নি ক্লাস 1 ড্রাগ হিসাবে। কনকমিটেন্ট আদার ডিজিজের ক্ষেত্রে সেটাকে রিকমেন্ড করা হয়েছে। এর মধ্যে যতগুলি ট্রায়াল ছিল, অনেকগুলো ট্রায়াল ছিল, নূর আলম হয়তো মেনশন করছে স্যার, আমি ওই পোর্শনটুকু মিস করছি আর কি। তারপরে অ্যাজ এ হোল দ্য প্রোগ্রাম ওয়াজ ভেরি এক্সেলেন্ট, এবং আমাদের হাইপারটেনশনের যে আমরা নলেজ গ্যাদার করছি, উই লার্ন এ লট। আমরা এভরিডে উই আর গ্যাদারিং এ লট অফ নলেজ ফ্রম মাল্টিপল ওয়েবিনার, বাট উই শুড অ্যাপ্লাই ইট as with our wisdom, so our patient will be benefited. So thank you very much, organizer. I will be happy if you organize such a wonderful learning session regularly with hot topics, then our people will be benefited much more. Thank you very much.
Thank you so much, sir, for your views. Now I'd like to request Dr. Zillur Rahman, Assistant Professor Cardiology in SCBD. Please, sir, give your valuable comments.
मुझे सुना जाए?
जी सर, we're hearing.
हेलो,
হ্যাঁ জি স্যার, শুনতে পাচ্ছি স্যার, বলেন স্যার।
थैंक यू इम्तियाज।
হ্যাঁ স্যার, শোনা যাচ্ছে।
Respected chairperson and co-chairperson and my respected panelist. हेलो, हाँ, शोना जाता है, ओके। Thank you, Noor. Usually he's brilliant in his presentation. I like to mention two things. One is measurement of blood pressure. Now, in the pandemic period, we very rarely measure blood pressure own hand. We like to depend our assistant, and they measure the blood pressure, and they believe it. So, as Noor mentioned, blood pressure measurement not a easy thing, but very easy thing. When we are careful, it is a very easy thing. We should careful about the measurement of blood pressure by your assistant, by our assistant, especially nowadays. One thing. Another thing is in blood pressure monitoring, home blood also depend nowadays the patients and their attendance recommendation. There's blood pressure is this and that in the morning, this and that in the evening. So we should uh, careful about the measurement, how they measure their blood pressure in the home. So this is the two different thing, and it is very important in case of mass hypertension and white coat hypertension. We must be should defend their statement regarding this blood pressure measurements, and by believing them, we should treat our patient. And next, last thing I should mention that we should treat our patient, not the blood pressure. We should treat our patient, not the blood pressure. When we like to the blood pressure in the optimum level, say 120, 70 in case of hypertension and lot of comorbidities. But patient get weakness and patient get postural drop. So in that case, we should careful about the treatment and individual our patient regarding the blood pressure blood pressure treatment. So thank you, Noor, and thank you, organizer, for this inviting me in this webinar. Thank you.
Thank you so much, sir. Now I'd like to request Dr. Kajol Karmoker, Assistant Professor Cardiology in ACVD. Please give your views on this presentation.
Thank you, Dr. Imtiaz, respected chairperson or president of BSI, Professor Fazlur Rahman, sir, respected co-chairperson, our Secretary General and Director of NICBD, Professor Mir Jamal Uddin, sir, respected all panelists, and a special thanks to Dr. Noor for his excellent, brilliant, and outstanding presentation of 2020 Global Hypertension Guideline. This is helpful for us, not only cardiologists, all physicians may be helpful by this lecture. I request him to publish the lecture in all social media, especially in our WhatsApp, Facebook, and another webinar. This is the very valuable topics to us and also the patient. So again, thanks to Dr. Noor, and thank you, moderator, for inviting me. Thanks all.
Thank you so much, sir. As you mentioned, today's topic was 2020 Global Hypertension Guideline by International Society of Hypertension, and today's presentation is done by Dr. Noor, Assistant Professor Cardiology in ACBD, and today's webinar Scientific Partner Development Pharma Limited and powered by Annie, Losartan Potassium, and Silnifil. This is the presentation. Now I'd like to request to say a few words about concluding speech, Professor Dr. Mir Jamal Uddin, sir, Co-Chairperson and Director in ACBD and General Secretary, Bangladesh Society of Cardiovascular Intervention.
Hello.
Sir, Balan. Hello.
Our final comment. Final comment. We shall have to control hypertension. We shall have to make awareness to the people for treatment of hypertension, and then we shall be able to reach the success. We shall be able to prevent the complications of hypertension. Thank you, Professor Amal Kumar Choudhury, Mamunur, Rashid, Sizar, and Kajol Karmoker, Professor Azam, and our Professor Fazlur Rahman, our president, and the speaker, Dr. Alam. And also, we must have to congratulate our pharmaceuticals, Delta, who has arranged this program. And I hope that everyone will be benefited from this type of speech and from this type of program in day to day and as well as our life. And I shall have request to them, pharmaceuticals, it should be, you please do it even in the peripheries, because you have linked to up to sub-center. You have linked, you are going, your drugs are going there. And so if these do this program in Upazila level, in the sub-central level, in the district level, then in the multidisciplinary tertiary hospital, then our people will be benefited more than only doing here. And this is my request to the pharma, and my congratulations to pharma that you have arranged such program. And hypertension, which is a very common disease, as well as having much more mortality to ischemic heart disease or hypertensive heart disease, developing the cardiac problem. And so we shall have to control the disease in the rural level, in the village level, in the district town level, in division town level, as well as everywhere. And so we shall have to congratulate the people once again, and all the speakers, all the participant, that is panelists, and our speaker. Thank you all.
Thank you so much, sir. Now I'd like to request our honorable speaker, Dr. Noor Alam. You did very good presentation, sir. Please share about your feelings about this presentation. Please say a few words with us.
Thank you for giving me the chance once again. The one thing I just forget to mention, but Dr. Zillur Rahman he mentioned very nicely that there are sets or targets of blood pressure lowering, but in 2020 guideline, they also mentioned that if patient could not tolerate, especially in elderly patient, so need not to follow the target level. Just low down his or her blood pressure at that level, which level the patient can tolerate. This is very important. Thank you, Zillur bhai, for sharing this. And I am also grateful to all panelists for their brilliant commentary and my presentation. My heartfelt thanks and gratitude to Professor Fazlur Rahman sir, Professor Jamal sir, Professor Amal Kumar Choudhury sir. He gave a very nice comment regarding today's topic. I also want to thank Professor Dr. Mamunur Sizar sir, Professor G Azam, Dr. Kajol Karmoker, and Dr. Zillur Rahman. Thank you very much for attending, and I also give thanks to Delta Pharma and Dr. Imtiaz for inviting me as a speaker. I am glad and feel honored to give a speech in this webinar. Thank you very much.
Thank you so much, sir. Now I'd like to share a few words from Professor Dr. Amal Kumar Choudhury and Professor Dr. Mamunur sir about losartan potassium and sildenafil. What is the role of this hypertension? At first, Professor Mamunur sir.
Sizar, unmute. Losartan potassium. Unmute kar, Sizar, unmute. Unmute.
You have become muted.
না এখন শোনা যাচ্ছে? এখন শোনা যাচ্ছে?
Yes, sir.
আচ্ছা। Regarding sildenafil is the fourth generation of the calcium channel blocker, and it is now important for the treating the, I think that is for the lowering the systolic blood pressure. It is very much helpful for the lowering the systolic blood pressure, and the side effect of the other calcium channel blocker like amlodipine, that is the fluid retention, and in case of sildenafil, it is less the fluid retention. This has the advantage over the amlodipine and other calcium channel blocker. And regarding the losartan potassium, in case of treatment of hypertension, that is AC inhibitor and ARB has started a glorious part to combat the complication of the hypertension, that is the instant organ damage, what is called. So these two drugs are very much helpful. One is for treating the systolic hypertension, avoiding the fluid retention, and losartan potassium is helpful for preventing the target organs damage. Thank you.
Thank you so much, sir. Professor Amal Kumar Choudhury, sir, please add something new, add something about losartan potassium and sildenafil. Please, Amal Kumar Choudhury, sir.
In that, I am delighted to ask some comment. I start my small comment regarding my friend Mamunur Sizar's already said the basic things. These are the two drugs, very important drug, one for systolic and another for both systolic and diastolic. And sildenafil also have some diastolic effect. But I like to the other side of the drug. To me, sildenafil is not absolutely preventable, prevent the pedal edema. It has also some side effect to pedal edema, for which it came to market. It has got no effect on pedal edema like amlodipine, but not true. Number one. Number two, it is less, relatively less potent to me than amlodipine. About sildenafil, this two comment, but also very good drug in 10 milligram daily. It's very moderate hypertension is very good. About olmesartan, it is well trusted and very potential drug for any type of hypertension, both individually and in combination with amlodipine. But the other side, I don't like to say the bad side, but other side or limitation is that I never use olmesartan in the setting of acute MI because there is no large study in acute MI. So only for hypertension without any MI, it can be used in chronic stable and CCS, chronic coronary syndrome, even then honest MI. But if there is any large MI, large myocardial infarction like anterior, extensive anterior or like this, I usually restricted to use this drug. Thank you.
Thank you so much, sir. Now I'd like to request Professor Dr. Fazlur Rahman, sir, for concluding this speech.
Dr. Imtiaz.
Yes, sir.
Imtiaz, before start, please,
Sure.
before concluding remarks by the President, I like to add a few.
Yes, sir. Yes, sir. Please, sir. Please, sir. Please,
Now
sir.
we are in the COVID era, and in this COVID era, I did not notice the entire lecture. Probably he has told. Even then, I like to tell that initially it was thought that this type of SC converting enzyme inhibitors should not be used in COVID, but finally it is proved there is no disadvantage of using this converting enzyme or ARBs in the setting of COVID. It should be treated. Previously, the drug which he or she obtained, that can be continued without any problem.
Yes.
Thank you so much, sir.
The trial also shows that it reduces the mortality also, sir.
Yes. Now, Professor.
So thank you very much. Actually, we all know hypertension is one of the important causes in the COVID era to increase the mortality as well as morbidity. I think this lecture given by our Associate Professor Noor and comments by our expert panelists regarding the hypertension will be helpful for the COVID patient and hypertensive patient in our country. And our fellows will also get the up-to-date information, including all guidelines of the world regarding the management of hypertension. This will be also very helpful. And last of all, what I want to say, actually, there is a group of patients in our country, those who think that if blood pressure is controlled by antihypertensive drug, they either stop the drug or want to stop the drug. This is very one of the problem in our country. In that case, we have to make awareness to our patient as hypertensive is a lifelong treatment. They should take the drug either low dose or full dose, whatever may be. They cannot stop the drug at all. Another issue, hypertension as it involves from head to foot, and its complication is very important, and it causes it silently. So Professor Mir Jamal has said awareness is very, very important, and that awareness should be placed up to city level, and that can be done by our company, our media, and others. And about losartan and sildenafil, what I want to say, as both are the good drug, that is why they are in the first line of treatment in the hypertension. So last of all, I thanks our director, NICBD, and Secretary General of Bangladesh Society of Cardiovascular Intervention, our treasurer, Professor Amal Choudhury, our scientific secretary, G Azam, our vice president, Mamunur, Sizar, our social welfare secretary, Dr. Zillur Rahman, our executive committee member, Kajol Karmoker, all are academicians as well as organizers, and they are all devoted for the implement of ancient objectives of Bangladesh Society of Cardiovascular Intervention. Actually, all of us are the interventional cardiologists. I think we have to get some idea, or we have to recapitulate behind intervention cardiology. That is why I request Dr. Noor to give a lecture on hypertension. From this lecture, we learn a lot. Maybe we learn from A to Z about hypertension, and others, those who are participating in the program, they also I think they also learn a lot, and this will be helpful for us as well as for the patient, as well as for our student and other fellows. Thank you very much. Last of all, I thank Dr. Imtiaz and Delta Pharma who arranged us a webinar, which is very informative for the peoples. And thank you all.
Thank you so much, sir. I'd like to express our heartfelt gratitude on behalf of Physician Tone and Delta Pharma Limited for your active participation. I'd like to special thanks our honorable speaker, Dr. Noor, sir, also Professor Cardiology and ACBD. I also give thanks Professor Dr. Fazlur Rahman sir, Professor Dr. Jamal Uddin sir, Professor Mamunur Rashid sir, Professor Amal Kumar Choudhury sir, Professor Azam sir, Professor Dr. Zillur Rahman sir, Dr. Kajol Karmoker sir. Unfortunately, we can't reach Professor Dr. Shaheed Hussain sir, but thank you very much for your valuable time with us. I'd like to express thanks to Delta Pharma Limited for sponsoring this program and for their product anin, losartan, potassium, and sildenafil. And also give thanks to all panel of experts and chairperson, keynote speaker, and special thanks our honorable speaker, keynote speaker, Professor Dr. Noor sir. Thank you very much for giving your valuable time with us. Thank you so much. Stay safe, stay healthy. Thank you so much. Allah Hafiz. Assalamu alaikum.
Wa alaikum assalam.